So the next question I'd like to answer is, what actually happens in a vision screening? And the answer is that it depends on the age of the child, and it depends on where the screening is done. We're very fortunate again in Massachusetts in that there's been a lot of effort that has occurred within the state to try to standardize as much as possible the way vision is screened using the best techniques that are available. And many people have worked very hard to try to identify the best approach to screening, the best techniques to ensure that the screening is as accurate as possible. But it's important to understand that no matter how good the screening is, if it identifies a child as needing a comprehensive eye examination, sometimes the result of that examination may be that nothing wrong is really found. So the parent may think that, well, I kind of wasted my time and my effort, and the child went through an examination that really wasn't necessary. The truth, however, is that a screening is never 100% accurate. Sometimes a screening might indicate that a child has a problem or might have a problem when in fact the child doesn't. And sometimes the screening may show that a child appears to be completely okay, but at some later time when the child gets an examination in some other system, find out that there was a problem, and that problem may have existed all along. So it's important to understand that screening is not 100% accurate. For better or worse, not many things in life are. Screening in Massachusetts can be done by a variety of different people depending upon where the screening takes place. There are two places where screening most commonly occurs. One is in the pediatrician offices or in the clinic. And in many cases, the screening is done by people other than the pediatrician. It may be done by a nurse, or it may be done by a nurse's assistant, or some other personnel. Hopefully, they are following the procedure that they are supposed to follow in precisely the correct way, and as a result, will end up with the best quality of result. Sometimes it doesn't always happen that way, and that's one reason that sometimes the screening may turn out not to be as accurate as we would like. Screening in the medical home or in the pediatrician office occurs for most children at some point in early childhood. The other place where screening occurs is in the educational setting, in the classroom. That can be in a preschool or in a Head Start or in a public school setting. And sometimes screening may occur as a result of various organizations that do screening. The Lions Club and Prevent Blindness and a variety of other service organizations, sometimes associated with college students or other volunteers, may do screening as well. So there are a variety of places where screening can occur. The procedures that are used may differ, but there is now, as I said, some standardization. The kinds of techniques that we use to screen the vision of children are usually in three broad categories. Number one, something most people are familiar with, are eye charts. So for adults, we always measure vision with eye charts that almost always have letters. For young children, letters don't work well for obvious reasons, so we use a variety of pictures. And those pictures are usually the kinds of pictures that provide us with an understanding of how well a child can see, that do not necessarily require a child to tell us out loud what it is they're seeing. They may be able to simply match a picture that's shown off in the distance with one that they're holding on their lap. And we can do that as a matching test. That also helps us to overcome the problem that we might face with some children who are very shy and don't really want to talk to a stranger, or for that matter, children who may not understand the language and may be confused by it. And we find through various testing procedures that the vast majority of children over 3 years of age, regardless of their language ability, regardless of their education level, are able to do, without a lot of difficulty, visual acuity tests. So That's one of the main techniques that we use. There are two others. The other technique will use an instrument that measures the prescription for glasses. It's usually a small computerized device that looks a little bit like a little small video camera. And the examiner, the screener, can hold that. The child will look at it, and the screener will be able to take a measurement that ends up saying pass or fail. And as a result, we can then determine what the child's status is from that. The third category are techniques that look to see how well a child can use both eyes together as a pair. Something very similar to a 3D movie, where if you're at a 3D movie and you put those special glasses on, you can see things sort of flying at you from the screen. If you close one eye, then you lose a lot of that effect. Maybe not all of it, but a lot of it. We use that technique because for that way of screening, you need two eyes working together as a pair in order to be able to appreciate certain kinds of things that are on the test. Children are able to do that very well from about 3 years of age on up. So again, the three techniques are visual acuity, using either letters or pictures, a test to see if the child is able to use both eyes together as a pair, and then another type of a test that usually employs a fancy piece of computerized equipment that determines whether a child may need glasses or not. And the screening is usually either a combination of those three or sometimes only one of those three, depending upon the circumstances.